So this is Professor Benian at Northeastern University, and sitting with me is Corey Balint and Sarah Benson, both working with me. So a bit about us. You're seeing pictures of students from past years who have joined us. Just a quick snapshot of who we are, and this is fluid, so this is sort of the current snapshot, but we have an internal staff that's heterogeneous, faculty in industrial engineering, full-time industrial engineers. Most of you have talked with Corey Balint, who formerly was my student, and somehow that didn't ruin him, and he turned out pretty well, and now he's here as a full-time staff employee as an engineer working on projects and also helping me run various things like the summer program. Office staff, staff who are helping us with visibility, publication, technical writing, grant writing. Recently we hired an MD, a doctor colleague of mine, part-time to just be a clinician in residence and advise those of us who are engineers on really what's going on in medicine related to the projects we're working on. And then there are actually the academic folks, the postdocs, the graduate students, and the undergraduates. So we have this postdoc program right now, 5, soon to be 6 postdocs who help me mentor the graduate students who help me mentor the undergraduate students in a cascading way. And it's almost like a department in of itself. We have dedicated space. And take note of the bottom bullet, the summer internship program, because 2 people you really want to get to know are Corey and Kendra. Corey is going to be helping really run the day-to-day of the summer program. Kendra has recently joined us, Kendra Gray, as an office administrative support staff. So she's the reach out to person on paperwork, hiring, direct deposit, pay, keys, logistics. My computer doesn't work. How do I solve this? How do I solve that? And then the bottom bullet is graduate student mentors. So the way we're going to do this is everybody who joins us for the summer will have a one-to-one senior graduate student, somebody who's been here with me for at least 2 or 3 years, who will just take you under their wing and help answer all those logistics questions that just seem to come up. So that's kind of us in bullets as a snapshot. This is a schematic of our institute and our mission, which is very simple, to improve healthcare, which is broken. And to improve it the only way we know how is engineers using industrial engineering. And improvement is at least threefold. We do research, we do application, and we do education. And we intertwine them as much as possible, and we design our mechanisms around them. So if I haven't talked with you about this, you're looking at our 3 platforms, and we've aligned different centers and funding mechanisms with each platform. We have a research center that's a consortium of a bunch of healthcare organizations. And we have an application center that's funded by CMS, and then we have workforce development, formal curricula, internship programs, postdoc mentoring programs, and all that sort of stuff. So the reason I'm showing you this right now is, of course, you're going to be participating in the summer internship program, mostly working on all these applied projects we have going on through our funding from Medicare and Medicaid. Some of you may want to get involved in some of our research, which I welcome, because some of you may want to be exploring what graduate school would look like, or just get a sense of what the heck is research in industrial engineering and healthcare. So I'll kind of come back to that. The slide you're looking at now is a schematic illustrating what Medicare and Medicaid has funded us to create, which is a regional extension center. So the HSERC, the Healthcare Systems Engineering Regional Center, is part of Northeastern University and intertwines with the different colleges here, mostly with the College of Engineering, some with business, some with health sciences. And then we focus all of our work on the healthcare system in the greater Boston area and nationally. It's important to know that and to think that the healthcare system doesn't mean hospitals and just hospitals. The healthcare system is broad and diverse, right? It's hospitals, it's outpatient clinics, but it's a bunch of other stuff. It's the people who pay for this, all the insurers, it's nursing homes, it's skilled nursing facilities, it's long-term acute care facilities, it's providing health in home health programs, and it's hospice and palliative, which is care at the end of one's life. So it's a pretty complex environment. And my hope is that if you're not a healthcare person and not familiar with it, that you'll come to kind of understand what the broader healthcare industry really is. So one slide on why are we doing this, really. So probably everybody has a sense for it, but just look at this slide for a minute. Healthcare is basically broken. It's costing a lot of money. It's costing more money in the United States than anywhere else, and the rate of increase in the costs is greater than anywhere else. And for all that money, we have an unsafe system that takes a long time to access, a long time to flow through. There are a lot of safety events, satisfaction's poor, and there's high variability provider to provider, state to state, patient to patient. So there's a lot of opportunity there. So the Institute of Medicine defines 6 things that are important, the 6 IOM dimensions, the Institute of Medicine. And all of these dimensions are basically things industrial engineers work on in any industry. So that's kind of, this is a problem that's perfect for us to be working on. So that's a little bit of overview of why we're doing this and why I've sort of focused so much of my career on trying to start a very large-scale program and figure out how to spread it across the country. Let me talk a little bit about the summer internship itself, and then we'll go to what's the calendar look like, what are the logistical issues we need to talk about. So here's a nice little clip art from PowerPoint trying to describe the summer internship program. So there's the summer, which is the middle piece, and there's the spring and the fall, which are the first circle and the third circle. So the middle piece is easiest to start with. You and some colleagues that you haven't met yet and we haven't accepted yet, but 10 to 15 people will land here right after Memorial Day weekend. And I've talked with some of you about your personal schedules, but on average, that's the week people will show up. And then we have the summer internship experience, which is the cohort of you working on a couple of projects and helping us with a couple of projects, mentoring, with some mentoring involved and some learning involved, and then we have to write it all up at the end of the summer. I'll come back to the summer experience in a minute, but what we're trying to build in is basically a reflection activity after the summer. So how did this benefit you? What did you learn? How did this help you make decisions? How did you grow from it? Or how did you not grow from it? So help us improve. And then if that's called reflection, we're calling the spring preflection, which is really just all the preparatory stuff. The logistics we need to take care of, as well as in late April, I want to give everybody an easy, light, but a reading assignment just to get your head into what we're doing, and ask everybody to write, you know, 1 page on what you would like to get out of this experience, because I think it's important to think about that, communicate that to us so we can do the best we can at lining up projects for you, but also to have a baseline to reflect on at the end of the summer. This is what I wanted to get out of this experience, and then afterwards, you know, what did you get out of it, and see how this benefited you. So I'll come back to all 3 circles in this. Typically, this is what somebody gets involved with during the summer, which is 2-ish projects. What we'll try to do is line everybody up with 2 projects to help us with. And a couple of things are important to point out here. One, these are all team-based projects, so you're not on your own. You're joining a team and working on a project collectively, and I'll tell you a little bit more about our team structure. The other thing to point out is 2-ish. You know, some projects are big projects and take a lot of time, and some projects move really slowly because it takes a while to get data from a hospital or some such thing. And so we're always doing load balancing and week to week, seeing if somebody's just overloaded and if somebody really is just twiddling their thumbs because their projects have stalled. So we certainly have people in the summer who are on 3 or 4 projects that are just slow-moving small projects. And then we've had people who are primarily on 1 project and maybe helping with another, but that 1 project's a huge project. So we just sort of try to manage this dynamically as time goes on. And then to fill in the ebbs and the sort of valleys as the work ebbs and flows, clearly, if you haven't picked up on it, we have a lot of internal processes that we need good process improvement on. So we have a committee structure working on, you know, all of our operations in the background as time permits to just do continuous quality improvement. So we'll get you embedded in some of that. And then the third responsibility is the whole purpose, which is learning and growth. So using these projects you're working on to learn and grow. Over the summer, we have a number of guest lectures. I actually teach a course that's an introduction to healthcare for industrial engineers, where we have a bunch of guest speakers come from the local healthcare systems and talk in class. And it's not a requirement. Students actually take the course for credit, but usually most of the summer students sit in on the interesting classes, don't do the assignments, don't take the exam, just sit in, particularly when docs come in and talk with us. And then there's a weekly meeting with your mentor and a reflection activity at the end of the summer. So here's a schematic hand-drawn of what our team structure looks like. And if you look all the way on the left, that column, so to speak, on the left, that's a pretty typical team. So there's a senior engineer or faculty that's really running a project. It could be Corey Balin running a project looking at over-prescribing of narcotics in the emergency department at a local hospital we're working with, and overuse of imaging diagnostics, because there's no real process in place for people who come into the ED complaining of back pain. That's actually a project we have going on right now. He's not doing that alone. It's his project, but he has a team. Graduate student, an undergraduate student, if this was the summer, a summer student, all working on that team together. So that's kind of the way we're running projects, in that team way where there's a senior person on it, and then sort of a cascading of people at different places in their education, grad school or undergrad. Here's a list of just a bunch of typical representative projects. We have at any given time 30 projects going on, so it would be impossible to show you them all. But everything from system logistics, you know, inventory, flow, layout, scheduling, to actually kind of flow and capacity, appointment access, how long people wait inside of a system, patient safety, adverse events, quality of care, staffing, workforce planning. So if you think about the entire field of industrial and systems engineering and process improvement, we kind of have a project going on in about every subject there is, which is, I think, a rich educational experience, because you could ask to get involved in a patient safety project because you have a passion for patient safety, or because you've done a lot of work in other subjects and you know nothing about it and you want to get some exposure. But one way or another, no matter what you work on, somebody here is working on all the other things. So by osmosis, you pretty much see and learn about every methodology applied to just about every problem there is. So here's actually a snapshot of a spreadsheet that's a couple months old, but 2 months ago, these were our current projects, just to give you a feel for the number of projects that are ongoing at any given time. Let me show you a couple, just so you can get a feel for simple through advanced applications. So this is a project. I have one slide for 5 different projects, I think. So this is a slide. Susie Goldstein's master's prepared industrial engineer, has been out there working for a long time, and she's running a project for us with a team. So they're looking at readmissions to a hospital. Big problem in healthcare. Patients are discharged and they shouldn't come back. So this focus on what's called the preventable readmission. And for some patient conditions, the defect rate, the return rate, is huge. So congestive heart failure, CHF, it's not unusual for a hospital to have a readmission rate of 15%, 20%. So 1 out of 5 patients who are discharged, who were successfully treated, and it's time for you to go home now, and we won't see you again. We see again within 30 days, so the 30-day readmission rate. So they've been doing some very simple work: data analysis, continuous quality improvement, process flow mapping. A problem is a lot of these patients who have been being discharged aren't getting a post-discharge follow-up visit with either a cardiologist or their primary care provider. So you're discharged and everything's fine and have a follow-up visit with your doc, and it's just not happening. And a high percentage of those for whom it's not happening bounce back into the hospital. So why is it not happening? So the focus of the project has been process flow analysis and trying to identify root causes and design them out of the system. So that's a process observation, process flow data analysis type of project, working on a team with a bunch of docs at this particular health system. And so this graph you're seeing at the bottom, this run chart of the cost of congestive heart failure patient readmissions over time, the project sort of started in the last third of that graph, and recently the readmission rate has been going down because more patients are getting their post-discharge follow-up visit. And so we're actually tracking the cost-benefit of this project going on. So that's one example of a project. Another example, we've been working in an intensive care unit looking at patient safety problem. A big problem in some hospitals. Some have completely solved the problem. So this thing called a central line infection. So a central line in an intensive care unit or anywhere really is if you're going to have a lot of needles and lines stuck in you over the days that you're in the hospital, instead of doing this over and over, let's put a port somewhere in your body. It's called a central line. And then, we infuse all the fluids in and out of that port, that central line. The problem is this thing's in you for 1 to 7 days, and it gets an infection, which is very costly. So central line bloodstream infection called CLABSI. And it's a patient safety issue. A lot of it comes down to human factors and how do we design a process that gets followed consistently. It's pretty interesting. Usually what's known about some infection control problems in hospitals is we actually know how to prevent them. The challenge is getting people to follow what's known, because you have very intelligent people who are very busy, and it's so easy to forget to do things. So how do you design the process to make the desired thing the easy thing? So we've been doing a lot of work on that type of problem. We've been doing a lot of work on logistics types of problems. Here's an inventory problem where we're looking at basically surgical supplies, peri-operative inventory, which is in this health system a mess. And why is it a mess? And they don't have standard ordering procedures. They don't have standardized preference cards. So if 4 different doctors are doing the same procedure. The bill of materials, so to speak, what they would like prepped and brought into the OR are different doc to doc, and why is that? So you have this heterogeneity, and consequently a lot of different items that need to be stocked. And so how do you standardize that which can be standardized? So it's pretty interesting if you've studied inventory control theory in an industrial engineering course. It's a world different out there in the real world. And most of that economic reorder quantity stuff really isn't the issue. And it's a total education to work on inventory in the real world. This is an example of a computer simulation project we have going on right now, where the question is, how come access is so bad, yet our rooms are so underutilized? And the logic by which patients are being put in rooms, there's no logic. So a couple of our students developed a computer simulation program and have been able to consolidate rooms dramatically and close. This health system was renting space across the street, kind of, at about $2 million a year because they simply couldn't room patients in their facility. We've pulled all the volumes out of this overflow facility back into the primary facility simply by doing computer simulation modeling and finding a better way to share and pool and pod rooms. So it's straightforward computer modeling leading to tremendous benefit. Now, I want to show you one research example because there are probably a few people who've had a course in operations research or linear programming. And this is a really cool project that one of my master's students and PhD students have been working on. And they've had 2 undergraduates helping out, supporting the whole project and kind of learning about this stuff. But the fundamental question in primary care, and particularly in team-based primary care, which is sort of a tenet of this new way, if you're familiar with the term patient-centered medical home. So now a team of providers, the primary care provider, the RN, the nurse, maybe the medical assistant, and others are sort of co-responsible for my care. So how do we schedule who works when? How do we create a scheduling template so that whenever I want to come in as a patient, if my primary care provider isn't available, somebody on the team is. You know, if you can't see me, hey, Corey's here and Sarah's here, somebody is here. And so it's what's called in linear programming an assignment problem. And it's sort of like solving a Sudoku riddle. You can't kind of do it non-mathematically. So how do we create a good scheduling template? So if you've ever seen a linear program, there's a set of equations one can write to describe the paragraph I just talked through that describes the problem mathematically and tries to optimize a schedule. And so we've developed this thing that looks quite complex, but it's embedded behind a nice Excel interface. Well, that's funny. And here are actually results of this project. So the whole notion of creating better schedules was predicated on the desire to increase continuity. Continuity we're defining as the percentage of times that I as a patient can see somebody from my team as opposed to see a complete stranger. You wouldn't want to go into, you'd like to go see your faculty for office hours, not a faculty you don't know. And if you can't, you either wait a while to see that faculty or that doctor, so access is bad, or you sacrifice familiarity. And familiarity and continuity leads to trusting relationships, and there's evidence of actual better care and better compliance to staying healthy and having screening, whether you're male or female, or child wellness visits. And so I'm showing you results of this project that we started over a year ago, where continuity has gone up, access days until I can get in has gotten better, compliance to colorectal cancer screening, breast cancer screening, pap smears, child well visits, all that sort of stuff has gone up, and consequently inpatient visits has gone down. So it's a really neat project where we found a much better way to schedule, and that's led to lots of good things happening in the healthcare system. So I wanted to show you all those examples because they sort of represent the breadth of projects, and there's a ton more. Let's just talk real quickly about logistics. So here's the calendar. So in the spring, today is the 28th, I believe. And then we want to do another phone call, which we haven't scheduled yet, but somewhere mid to late April to go over some more things. And I think at that point, we'll have something that we want you to read. We'll have some paperwork. You know, we need to do what's called onboarding. Onboarding here, so we want to start setting people up with computer accounts. So this first week or two, you're not just twiddling around, logging in under our password. You can actually get access. But if we can figure out who's going to work on what projects, there's paperwork we need to start with the healthcare systems because they don't want us milling around their system and observing patients and so on, and just seeing what's going on. If you haven't gone through some sort of orientation with that hospital, sign some documents about your, non-disclosure, and this thing that's called HIPAA. The other thing I'd like to do in the spring is this pre-reflection exercise, really, which is, so start thinking about why are you doing this and what do you want to gain from it. So that's the spring calendar. The summer, that first week that you're here, for most of you will be starting the Tuesday after Memorial Day weekend. And we'll take you through each morning a general orientation and some training and finish up any onboarding paperwork. And we'll do the final project matching. We'll try to do some of that in the latter part of the spring. That'll be week one when you're here. And then the bulk of it, June through August, is just the summer internship, working on team projects, getting involved in our work, learning, growing, contributing. And that includes on a weekly basis. We have a Monday meeting here where everybody gets in a room and we have a structure and an agenda, but we kind of go around the room and learn how projects are going. And then also on a weekly basis, meeting with your mentor, and every Friday I gather all of the undergraduates and summer interns in a room, and we just do a round robin for an hour just so that I can stay connected. And that's what goes on a weekly basis. And then for most of you, at the end, which would be the week of, for most of you, the 10th through the 14th of August, some may leave earlier, some may leave later. We've had some of those conversations. There'll be reflection. So we have this sort of one-page writing assignment you do. We have a PowerPoint that you put together. It's a template where you describe what you've worked on, the projects you've worked on, and what you've learned. It's pretty simple, but it's important for us to capture that. It's important for you to do that. It's important for us to capture that so we can evaluate how we're doing and how to make this whole thing better. So that's the spring and the summer, and then in the fall, I'd like to have one or two calls like this where we get everybody on a WebEx and continue to talk about those projects you've worked on and a little bit more post-reflection. Some of our projects, we actually want to invite you to participate with us in writing them up and submitting them to conferences. And that would be discussions we have in the fall, where actually just this morning we're talking about the Institute of Industrial Engineers conference coming up and what projects from this past year we're going to have some of our faculty together with the students present. So that's the kind of the calendar in a snapshot. Logistics, I want to again make sure you know Corey's name and Kendra's name because they're going to help coordinate dorm rooms for those of you who want to grab a dorm room on campus, and a lot of the startup stuff, computer accounts, HIPAA training. So HIPAA is basically patient confidentiality, the Healthcare Information Personal Protection Act. And it's critical that everybody be oriented to what HIPAA is, and there's an online training module. We'll send out that link. And it's important because it's important, And it's also important because we want to be able to tell the health systems where you're going to be working on projects that we've all been oriented to HIPAA. The gist is you're going to learn things potentially. You may see patients when you're doing process observation. There's some low probability you may even see somebody you know, but you're not going to tell anybody. That's at the high level. Below that is, we get a lot of data, and most of it's de-identified, but if it's identified, if we could actually look at somebody's street address, all that data is locked down in a secure way. And so, patient protection, patient-identified data is protected. That's the gist of HIPAA. A lot more to it. That's why it's important for you to learn something about it. So what's coming up is mid to late May. We're going to circulate a list of the projects we know we're going to be launching in the summer and the current projects we have going on. I know Corey's been reaching out and has a spreadsheet already on who's interested in what particular things, and we'll do our best to line as much of that up as we can. And then for most of you, all of this really starts the day after Memorial Day. And we'll just sort of have coffee, donuts, and orientation that first day, which is May 27th. So that's everything I wanted to step through. I'm showing you this last slide. So the question is, what else and what questions do people have? But I'll put this last slide up again because, importantly, it has Kendra's email and Corey's email, which most of you probably already have.